Welcome, everybody. It's my great pleasure to welcome you all to the launch of the Transitions Project today. My name is Dörte Bemme. I'm a lecturer in global health and social medicine here at King's College London, and it's really my great pleasure to welcome you all here and to lead us to this through this afternoon. Let's start with a tiny bit of housekeeping. The bathrooms are out the door on the right-hand side, and I will say if you need a little break and a bathroom break or walk around a little bit, please feel free to do so during the presentations as well. It will be a little while until our next official break and then later our reception. In terms of the outline of the event, we have 5 fantastic speakers to set the stage and frame the topic for us today. There will be an opening presentation today from Devora Kestel from WHO. Then we have 3 presentations from our researchers from the project telling us what their ambitions and plans are, what they're going to do, and a closing commentary from Professor Hanna Kienzler. And just to set the stage, I also wanted to kick us off a little to think about deinstitutionalization and why it is that we're revisiting, or these fantastic colleagues of ours are revisiting the history of it and what can be learned from it. Because deinstitutionalization always points to this very complicated intersection of care and control in psychiatry. And that makes also psychiatric care very unique among the medical disciplines and also global health. And there is sort of a dominant history of deinstitutionalization that has been told many, many times that evokes the figure of the asylum, of course, and its more contemporary cousin of the large-scale inpatient psychiatric hospital. And these places are often imagined as sort of situated outside the periphery of a city or a society. They're associated with exclusion, with social control, and with stigma, both of those who are confined within and also those who are working there. And the history of deinstitutionalization, in a way, has often been told in a somewhat linear way, as beginning in the 1950s with the onset of psychopharmacology, enabled by this drugs development and driven by a scandal and critiques of social reformers and the anti-psychiatry movement. These carceral institutions were sort of gradually closed or downsized in favor of community-based and residential forms of care. And despite of this sort of success story, this kind of standard history of deinstitutionalization has also acknowledged that the processes were uneven and often created new problems, such as the homelessness in communities or what's called cross-institutionalization, for example, with prisons. So this story seems long in the past and somewhat settled. But when you actually work in a global context and take a global lens, it looks rather different, and you find quite quickly that this linear story of deinstitutionalization is in fact quite well untrue, or at least limited and incomplete, to say the least. So when we take that lens, we will quite quickly see that deinstitutionalization in fact took many forms and trajectory in different parts of the world. And the community was not simply discovered in the 60s, but has always been an integral part of many care arrangements. Deinstitutionalization processes have in fact always been multiple in direction and in rationale. They've been partial and fragile. They're profoundly localized and entangled with political projects. And to capture this broader, more complex history and to learn from it, and what is needed and actually on offer here, and this is how we end up circling back to this fantastic event, is a polycentric history, a polycentric approach that tells the story from many vantage points, and especially from the vantage points that have often been overlooked. So it's my great pleasure to support my colleagues here in launching their project today, which emphasizes that such transitions in the plural have always been multiple, and they're always deeply grounded in local history. In this case, the histories of Latin American psychiatric reform and social medicine. And I very much look forward to learning more about the case studies they will bring to us today about Chile and Brazil, but also the institutional history of WHO. And for this, it's actually my great pleasure to introduce our first speaker, from WHO, Dr. Devora Kestel, who's the director of the Mental Health Mental Health, Brain Health, and Substance Use Unit at WHO. She's a senior global mental health policy expert with over 30 years of international experience across Europe, the Caribbean, and Latin America. She has led and advised national mental health reform efforts with a strong focus on community-based systems and human rights, and she holds degrees in psychology and public health. Please all help me welcome Professor Devora Kestel for the opening presentation.
Thank you very much. Good afternoon. We are tempted to say good morning, good afternoon, good evening, because we have a lot of webinars, right? And but can say maybe only good afternoon. Thank you very much for this invitation. I was recalling and saying hello to some of the colleagues that I met, some of you around 8 years ago. I was kindly invited to meet this network of young mental health professionals from Latin American countries, and many of them are here, and it's great that you are here and that you are involved in a project that for me is absolutely important, relevant, and needed. And I was amazed at how many times you managed to say deinstitutionalization without even once get trapped into the most difficult word maybe in the mental health field. I had help in the preparation of this presentation, and it's also here in the room. But I had the task to think a bit about why this is important for me and to talk about a bit of my own career. I need somebody to check the time so that, okay, you are great. Because the risk is, and the reason of having a presentation prepared is that I could speak maybe for the day or more on this, right? And then when I was looking at and trying to think about that, I was looking at the pictures of the psychiatric hospital where I started, where I was a student in Argentina, and I had one unit that I had to visit this place. I couldn't find pictures from back then, but I have found these pictures that really represent what is in my memories, how people were living in that institution that had 3,000 beds, and I was working in one area that had 100 male patients split in 2 bedrooms, and you will see something like that, and you will see people on the behind the bars, and you will see people tied up, particularly at night, so they didn't bother the nurses to go to, when they had to go to pee or whatever. And this, there was an expression of the gatosos, the cats, that were people just lying on the floor all day long and without anything to do. Another important characteristic of that was the smell of abandonment. People smelling because they wouldn't take care of their hygiene and nobody will help them doing that. And the smell of the closed area and the smell of dirt. The smell also of the chemical products used to kill the smell that was then worsening the smell, right? Those scenes and the smell I have met in many hospitals in my psychiatric hospitals in my career. Internationally, that's global mental health, the smell of people with a psychiatric issue, right? I mean, they're not criminals, they just ended up there. And my issue was why? Why somebody locked for 20, 30, 40, 50? I met one 48 years, was in the hospital. Not because of the health condition, right? So how do we work around that to change that reality? At the time of university, I came across this man that is called Franco Basaglia, who have said many interesting things. I recently had the chance to watch a video that his grandson, called also Franco Basaglia, did for a celebration, and I was impressed by how valid are the things he said I'm bad with math, but 40, 50 years ago. And this is one sentence that I remember always. And I translate it from the Italian. And it says, how could I propose anything psychiatric, psychological, or a therapy, biological or psychological? He says, in an institution where people are treated in that way. There's no role for a psychiatrist or for psychiatry, or today we could say for mental health, in a context where there is no freedom of communication, freedom of a relationship between the ones that are supposed to take care of people and people themselves. Now, sometimes the language that he uses is a bit outdated. He speaks about the illness and mentally ill and terms that we might not use today, but what he's saying is absolutely valid today. So I invite you to look at, this is a documentary that was wonderful from what he did in the 60s in Gorizia before going to Trieste. But then he went to Trieste in Italy, and that's where I went because I learned about that experience and I wanted to see it. And then I was struck by that, la libertà terapeutica, freedom is therapeutic. And so I remember very, very clear the shock, the impression of seeing people that were still living in the old psychiatric hospital with a freedom to do whatever they wanted in a carefully taken care of context. People were not abandoned at themselves. They were carefully helped to live their life in the community where they were. And that, I think, then I had the absolute privilege of going to, with a successor of Franco Basaglia that was called Franco Rotelli, I had the privilege of going to him, with him, to intervene a psychiatric institution that was still in Italy in a town called Udine. And so I was having the opportunity to work through a deinstitutionalization process in the rich part of northern Italy, where despite a law saying psychiatric hospitals are not the answer anymore, they kept it active. And so I went through the process, and it was, I think, what definitely gave me also the technical, not only the values and the conviction that this was to be done, but also the how to do it. Right? What are the steps needed, and what are the different components that need to be taken into consideration? However, as you can see here, is that deinstitutionalization is way more than a technical process. Because it's value-driven, because it's possible beyond the resources available, but it needs to be the objective clearly identified in order to do it. And also the issue that gains are fragile. And maybe we will hear later about this from the country experiences, or maybe in another round, but it's hard to maintain achievements obtained in this field. So I had then the opportunity to work in somebody's calling, in Eastern Europe in a few countries. Then I went to the Caribbean. Also, I worked in a few countries, and always I found the need, but maybe because my eye was looking into that, to work on issues on deinstitutionalization. Interesting, I was thinking, again, looking at these issues, in the Caribbean, for example, the conditions were exactly the same, except the smell was different because you have all open doors because of the weather. So that was the only difference. Otherwise, it was mostly the same. But without significant resources, the reform was possible. Changes were possible. So alternative solutions were possible. And then the question became this. And we are looking at the notes I have here. Yes, it's more than 30 years. I don't know how many countries I have visited. And the lesson learned is that we need to find a more clear, systematic way of identifying systems that could be built without the need of punishment, coercion, segregation, isolation, etc. And then that means that we need to find ways to support people in the community. And the person that has that, whatever problem might have in the mental health field, plus their relatives, their family members, because otherwise that drives the need to separate the person from the family, because the family cannot cope with. Well, we need to find ways to support that. And the reform needs to be sustained over time. We need to find a way of doing that so that we don't go back again to the starting point. I always wonder if other fields have the same challenges, and I still didn't find similar examples from other areas. We have now many years since the first reforms took place in several countries, good or bad, some very good, but still we have many countries with closed hospitals. We are just finishing a survey that we do every few years with countries, and I learned yesterday that from 60 countries that only provided answer to this question, there are more than 500,000 people living in institutions, only from 60 countries, 500,000. We are 194 countries if we don't exclude the ones that recently are changing their mind, right? So 1/3 of countries said we have 500,000 people living in institutions. That is huge number. And we can think about all those that are also abandoned in the streets, et cetera, et cetera. So we need to find a way to help countries deal with this, solve this challenge. We need then, of course, to expand community services, as I was saying before, and the human rights frameworks that since then, the beginning of those reforms became very strong and consolidated, need to be then not just considered as an ideal to reach out to, but also as a tool in order to find the solutions that are needed. And in that context, the people with lived experience in many countries, particularly in some parts of the world, like Europe, the US, etc., they are having a louder voice. This is not everywhere, still a long way to go. But yes, we have seen that deinstitutionalization is achievable everywhere in different parts of the world. We have seen it, of course, in the US, in Europe, and in the US. If they would have followed what they started, would be better. But anyway, it was a way forward. There are examples in as I said, the Caribbean, Central America, South America, we will hear after. So it is in some parts of Asia, things have been done over time with significant, important results. So how do we move from there into a reality that eliminates, deletes this as part of the answer? The global landscape is, sorry, I'm a bit, the global landscape is a bit what I said. Still, countries spend most of their funds in psychiatric hospitals. More than half of the funding goes to psychiatric hospitals. No, that was this side. The psychiatric, so many countries have only psychiatric hospitals as an answer, and people are staying more than needed as a long-term care. Anybody working in psychiatry knows that the acute phase that might need hospitalization, a psychiatric bed in one way or the other, is not that long. So here is already something wrong, right? And we are not talking about 20, 30 years, but months is already too long. And as I was mentioning before, 500,000 people in psychiatric institutions, and some other numbers that we are coming with that tell us there is a long way to go. Why is change so hard? Well, there are restrictive laws, or the political commitment or will is limited, and therefore chronic underfunding. There is resistance, and the resistance is a lot heavier maybe from the health sector, and most of all from the mental health sector, in order to change a way of doing things, as opposed to what we have been doing forever, and it has been so comfortable. Why will we change? The need, it's a difficult process. It's complicated. Hopefully we will hear a bit more soon. It's complicated. It's a difficult process, requires a lot of foresight, coordination in many partners. I don't see 5 minutes. Okay. And that is, it talks about commitment, therefore, right? And we know in many, at least low and middle income countries, the governments are active a couple of years only, because then they are talking about planning about the re-election, and they can't commit for long-term investments or issues. And the issue of stigma altogether is very present. So we need to reframe that narrative. You will have these slides, so you will look at them, because I will go a bit fast. We have now a current mental health crisis that conflict, climate change, etc., is definitely after the pandemic, widening inequalities, and the treatment gaps for mental health conditions is still very high, wide. There is a constant risk of going back, right? 71% of people with psychosis not receiving access is a huge number. It's a huge percentage. And we tend to ignore that. And I was talking, because there's a lot of talking about common mental health disorders that affect many more people, depression, anxiety, but having one of these conditions and not getting any help is devastating for the person, could be, for the person and for the context, the family, etc. And still they don't receive support. We need then to stop thinking about reform as a steady, linear course of action. We know it's a difficult process, and we need to keep reviewing the process and understanding what has worked, what not, and then how to move on. We need to rethink where the innovation comes from, and what is that really deinstitutionalization mean. We heard earlier about some of the issues that we used to call it trans-institutionalization. We, yes, close the institution, but send them everywhere else. That's not what we need to look for. The relationship between psychiatric institutions, the community, general healthcare, the inclusion of mental health as part of the health and social sector is a must nowadays, because we know it works, we know what needs to be done, and that will help then changing the narrative of the need of an isolated, faraway institution. And of course, working with the community affected, families, etc. Challenges, we a bit talk about that, the sustainability, equity, participation. All the time I was thinking about that. I was mentioning also earlier to somebody, the issue of poverty is critical here, because people with money don't end up in those institutions. Mostly they will go to a private setting or pay somebody to take care of them. So it's really, equity is a big component. I'm going a bit fast because I know I'm behind. But we have projects like this one, right? The transitions, and need to research and look at the regional leadership to make sure that we learn more. And we were talking this morning with Cristian, what are the other elements that are there that need to be taken into consideration, that need to be properly understood, and then used in order to promote that these changes will take place elsewhere. Well, we have tools. That's a slide where I promote the work we do. I can go faster on that. Okay. And then to conclude, back to history, Kosovo, 2001, Mark used to use this picture as well. I had the opportunity to work in an institution also there where this human being was living, and unclear gender issues, and this is not because of the current challenges or discussions on gender, it's because you didn't know what was it with that sweater with an A, probably was the name of the area, the ward where she was living. It's she, I said it. And to this person, that was after a couple of years of work, we managed to open some residential housing opportunities, and this is the same person. And this is what makes these initiatives worth. This is possible, and we are all, the mental health community globally, committed to do the best to make sure that this is not possible anymore, and that that is the way forward for anyone, anywhere who has a mental health challenge of any kind and end up in those institutions. So here to close again, thanks to Transitions and the project, because we really think that with that, we can help driving the change that is needed. Thank you.
Thanks for this fantastic opening conversation. And now it's my great pleasure to introduce actually the transition project itself, and we will next hear from Cristian Montenegro, who is a senior lecturer at the Department for Global Health and Social Medicine here at King's. He's a medical sociologist and global health scholar whose work explores the role of service leader knowledge and intellectual contributions of the Global South to mental health policy. His research spans participatory mental health, political global health, and mental health systems reform in the Global South. His talk is entitled Introducing Transitions, the Ethics and Politics of Psychiatric Deinstitutionalization in South America. Welcome, Chris.
Okay, I need to open my slides, so 1 second. Okay, so well, first of all, thanks, Devora. That was a great presentation, a great introduction, like a great overview of what the challenges are. And we know that the challenges are big, are complex, and this is a complex area of policy. And maybe we underestimate that, and that's why we need to look at this again and consider more factors, more histories, more experiences. Thanks to everyone who had the time to come and to see what we have to say. This is just starting, so we hope that we'll have something similar with actual results. But we will present what we aim to do, what the problem is, how we are approaching this. Thanks, Dörte, as well, for introducing and helping, and well, all the team. So, over the last, I would say, 10 to 5 years, deinstitutionalization seems to be back on the agenda of different groups. It's a more diversified agenda. It's strongly dominated by a disability rights perspective. It seems as if the topic itself has moved from different registers, from different disciplines even, from different literatures even, across the years. That makes it a very exciting thing to observe and to attend and to look again. We have different initiatives in Southeast Asia, initiatives in Latin America, new documents, new frameworks, new attempts, new efforts, new coalitions addressing this issue, looking at it. We have the Convention for the Rights of Persons with Disabilities, who was an important reframing of what is actually the standard, what is actually the expectation on how we treat people with psychosocial disabilities, including people with mental health issues. This also created a wave of activism around what to do with institutions and how to frame the problem. The notion of reparation has become one such angle. How do we reparate for the people that spend 10 years or 20 years or 40 years, as Devora was telling. It's not just an issue of transitioning them from one place to the other, but also recognizing that harm, thinking about accountability. So the discussion is very intense. There are, of course, recurrent exposés. It seems that every time we bring like a journalistic team to one of these places, you will find something wrong going on. It seems to be a constant. Every 5 years, every 10 years, we have something that kind of shakes the agenda a little bit and reminds us all that something is happening and that we need to do something about it. We have emergencies, war zones, natural disasters, increased tension and polarization across the world that also has to make us think about what happened in these institutions in context of war, in context of disaster. And history tell us that sometimes they are the first ones that are abandoned and nobody really cares about what happened when everybody needs to move somewhere else. So it's also something to bear in mind. So we have this scenario, we have this back on our agendas. But on the other hand, and kind of paradoxically, at the same time, sometimes we have the feeling, or I have the feeling that when I talk about the institutionalization, it seems to be something that was already dealt with, something in the past, something in black and white, something from a distant origin story of how modern psychiatry actually works in the present. It serves a certain narrative role in talking about how things were and how we are moving into something different, a refining of treatment options, a refining of language as well. So we've been refining things, but as Devora was just showing, and as the global evidence in a way show, the situation hasn't really finished. It's not really part of the past, and it's happening in many parts of the world. Within global mental health, which is this relatively new field, I would say like 20 years old field, if you do like a simple Google search on how many times the word deinstitutionalization is mentioned within global mental health as a field, it's very few. It's definitely not a focus. The focus is more on need for treatment, gaps of services, ratios of professionals versus population. So discussing closing things doesn't seem really compatible when the focus is on scale and gaps and the need for treatment. So the notion of the need for treatment sometimes, although very justifiable, it means that the discussion on deinstitutionalization and how institutions work is sometimes not really prominent. But what underlies some of these perspectives in this notion that the institutionalization is in the past is a very strong narrative of progress. And Dörte was mentioning this at the beginning. We have the notion that some countries are ahead in terms of transitioning services, some countries are behind or are on their way. And we have a very kind of a strong sort of a timeline of what does it mean to be a modern mental health system. Reform sometimes is thought of as a matter of time and resources. As Devora was saying, it is possible to make transformation regardless of funding, and a big aspect of this process doesn't really have to do with resources. It has to do with a model of how we conceive treatment and conceive people. But it is very common to think of this as we should wait for countries to arrive at this. This is kind of a natural process as there is a realization, as there are options and alternatives. And the vision is sometimes that psychiatric institutions will be naturally phased out, will become obsolete as treatments improve and as stigma recedes. And that means that rather than confronting or entering into a polemic with existing institutions, the thinking is we should just invest on everything else until this institution becomes unnecessary. Unfortunately, also the evidence of the persistence of psychiatric institutionalization and long-term isolated treatment actually tell us that that's not necessarily the case. In 2023, with some colleagues from Chile, we did a scoping review of facilitators and barriers to psychiatric deinstitutionalization. And the first thing we notice is that this narrative ignores a lot of the complexity of mental health systems transformation. And not just mental health system in the abstract, just working with a single institution, a single hospital, involves a nonlinear process, involves advances and then coming back. It's related with political will, with political coalitions, with values, with service models, with service philosophies. And therefore, this notion of a linear progress, this really doesn't hold. And even in high-income countries, we can see, again, the use of coercion, new discussions about why it's actually necessary to lock people up when they have a mental health condition. So it seemed that this is kind of a living struggle, something that doesn't really end at any point. In this review, we basically looked at all the publications around the institutionalization from the 1960s. It took us like 2.5 years to complete this work. And although the main focus was, okay, what are the barriers? What is stopping this? What are the facilitators? Very typical kind of a distinction. As we did this, we realized a lot of absences in the knowledge base itself, in this amount of publications. So the first problem was, of course, that it was mostly developed in the 1970s and 1980s. And that's when we noticed that in academic mental health research, the institutionalization after the 2000s started to, the engagement was more limited, was smaller. And the examples, well, and the second problem was the focus, because the focus of this literature was mostly clinical, and it was looking at outcomes. So comparing outcomes between people who was deinstitutionalized versus people that remain in institutions, for example, as if that kind of evidence would support the transformation. So that was the orientation, and not much on process, not much on how you do this. What does it mean? Where do you start? Who did it? What is the process itself? Another big absence is the absence of patients, of course, patients' accounts, caregivers' accounts, and crucially, healthcare workers. Healthcare workers were excluded. Women in general are not really present or are quite excluded from histories of achievement and histories of progress too. So different voices marginalized from the evidence base. And finally, location. With most of the evidence coming from the USA and Western Europe. And this is where the Transitions Project kind of starts to make sense. So we know that the social sciences in general had a very big interest in psychiatry in general over the 1960s, over the 1970s. There was a strong engagement. And if you think about Basaglia, that Devora was mentioning, he was part of a strong intellectual milieu, a strong counter movement in a way, in Europe, but international at the same time, with different voices, not only from, and not mainly from psychiatry, but coming from different angles, from philosophy, from sociology, from anthropology, from history. The debates were very transdisciplinary. So the engagement was really powerful. But what happened outside of Western Europe is what we don't know at that time. The receptions, the perceptions, the discussions. This is a very, I would say, European story, a Eurocentric account of the process. And this is what we want to start problematizing and enriching and finding those other histories outside that framework. And we will look at Brazil and Chile, and I will explain why. The aim of the project is to situate and historicize psychiatric deinstitutionalization's ideas and practices, tracing the global circulation and local re-elaboration of these ideas, including therapeutic innovations and normative agendas. And we talk about global circulation, because in many parts of the world, and also in Latin America, these histories are really national, are histories of national psychiatric progress and how countries have gone from one stage to the other, or from one situation to the other, without really looking at the interactions between countries, the exchange of ideas, the movement of policy entrepreneurs between countries and between regions of the world. And this is something that we want to look at. And then the local re-elaboration means that this is not just copying or mimicking what seems to be the way things should be done, but it is a reinterpretation, and it has to do with prior national trajectories, as we will see. So the research questions and the work packages this is an attempt to make this graphic. We will look at local debates in Chile and Brazil in the 60s and 70s particularly, local debates, local receptions, what the psychiatrists were saying, what other groups were saying, how this became kind of a politicized discussion. And then parallel to this is the specific social and political processes that shape this in those countries. And this is work package 1. Then work package, this is 3 and 3, apologies for that. It's not intentional, yeah. But this is work package 2, here, this should be a 2. We want to understand how psychiatric deinstitutionalization became, moving from something that was very localized in the UK, in France, in Italy, with very kind of a national specific takes on this, like psychotherapeutic approaches in France and Basile in Italy and therapeutic communities in the UK, how this became kind of a single, more broader concept of deinstitutionalization, and how it became embraced by international organizations like the WHO. What happened there? How was the process? Who pushed for the internationalization of this expectation? And then the final work package is that we want to look at the present, and we want to do field work with groups, with places where this discussion is happening now. And we want to contrast how different it is today from the debates in the 60s and 70s and the politicization in the 60s and 70s. What are the new political actors? What are the new forms of critique? What are the groups that are embracing this or opposing this? Okay, so why Chile and Brazil? Chile and Brazil are pioneers, according to the Pan American Health Organization, many evidence of progress. Chile and Brazil are cases of relative success, consolidation of this process in a gradual way over decades through laws, through mental health plans, like are countries that turn this into national policy and have followed this path slowly but very persistently in spite of certain political upheavals in the case of Brazil that represented a bit of a I would say, challenge to the process. But both countries have this fame of being good examples, but very different examples. They have comparable political trajectories, starting from socialist aspirations in the 60s and 70s, authoritarian rule of different duration through the 70s and 80s, and then their struggle to have democracy again. And psychiatry was really part of that. And we want to understand in what way, how discourses of human rights, discourses about torture, for example, were very important for the creation of a notion of mental health policy in both countries in different ways, but that was a strong value that makes it somehow unique. But you have wide cultural differences, differences of scale, types of government, geographic, social, political differences. So there is a good balance of sameness and difference in order to make this comparative case. Dörte? Thank you. Okay, just briefly, if you ever Google Latin America deinstitutionalization, you will find Caracas. Caracas will be there. It's a very important milestone in the 1990s, right after at least 3 countries ended their dictatorship, after 3 countries recovered democracy. It was like there was like a team waiting for that to happen in order to have this moment in which it was possible to do mental health policy. The policy space was open again. And here is the original one. And this is 15 years after, this is 20 years after, and this is 30 years after. And I think we have a couple more. So it really became kind of a measuring stick, a way of expressing a shared commitment. The main values was about transition to community mental health, of course, a strong focus on primary healthcare, which is, I would say, different from what happened in Europe, for example. Primary healthcare became kind of the mechanism, the means through which to conduct this restructuring. And the word at that point was not deinstitutionalization, it was the restructuring of psychiatric care. But beneath the declaration, there were unique national processes. And if we look briefly at this, and Felipe and Sofia will talk a little bit more about it, we have military dictatorship, those two bars in Brazil and in Chile. And in the case of Chile, we have a strong period of interesting debate, proposal about closing institutions, proposal about community mental health that were really ahead of their time in terms of thinking about peer support, the role of communities, how people could do this on their own, how they could learn to help each other. That all happened in the 70s. The military dictatorship, basically all the psychiatrists were exiled. And in Brazil, dictatorship was different than in Chile. And during dictatorship, and in a way, as part of the process of ending dictatorship, a mental health workers movement emerged. And the notion of deinstitutionalization became part of that process, of that recovery of democracy and freedom. And then we have the Caracas Declaration. And our concern here, what we want to understand is how this declaration had its own history. And sometimes it replaces that those prior national developments that we want to kind of rescue from history. Here's the team. Sofia Bowen will talk after me, right? No, after Felipe. Oh, sorry. So Felipe will talk first from Rio. We will introduce them one by one, so I'm not going to spend much time on this. We have Delia, who's the PhD student, Madeline, who's here, project coordinator, and we have partners in Escuela de Salud Pública en la Universidad de Chile, and the Instituto de Medicina Social in Rio de Janeiro. We have great partners within Kienzler, the Global Health and Social Medicine, where we are based, the Brazil Institute, who has helped a lot with this event, so thanks. The Center for Society and Mental Health, and the Global Health Institute. And here are some of the partners in Latin America. So what we want to achieve, basically, what the vision is we want to consolidate an interdisciplinary social science approach to mental health reform. We know that social science has been part of this. It was engaged particularly in the 60s and 80s. We want to see how the social sciences become part of this again. What are the angles? What are the proposals that will enter into a good dialogue with policy? We want to foster north-south reciprocal learning. We know that the UK and the NHS is learning a lot from Brazil in terms of primary healthcare, for example. And we believe that in terms of mental health care, there's also a big chance to start this process of learning. And we want to engage with and join policy and advocacy efforts that are related, compatible, and resonate with what we're trying to do. Okay, so thanks for the time.
Thank you so much, Cristian, for this introduction and overview. And it's my great pleasure now to hand the floor over to Felipe Szabzon, who will introduce the first case study. And his presentation is entitled Situating the Brazilian Mental Health Reform in the Global History of Psychiatric Deinstitutionalization. And Felipe Szabzon is a psychologist and interdisciplinary researcher with a PhD in health and welfare dynamic. He's affiliated with the Brazilian Center for Analysis and Planning and the Institute of Psychiatry at the University of Sao Paulo. His work focuses on mental health systems, psychiatric reform, and the politics of care in Latin America. And he combines policy analysis with ethnographic research to explore state practices, citizenship, and institutional change. Felipe, over to you.
Thanks, Dörte. Hi, everyone. Well, I know I come from very academic spaces, and I was told here that I have to speak in a TED Talk format, that I will have a chair, and I need my paper. We'll see. The presentation will help to make it very nice presentation. So before I start, I would like really to thank Cristian first for the invitation to join the team, to join this project. I would also like to thank the Department of Global Health and Social Medicine from King's College and the Institute for Social Medicine that is also supporting the implementation of this project. Am I speaking properly on the microphone? Yeah? Can you hear? And I also would like to thank Wellcome Trust for believing in this idea and supporting and financing it. So it's really a pleasure to be here. It's also a pleasure to be here in King's College. I have collaborated with many colleagues from this house in many different projects, but this is the first time I'm sitting here as an affiliated member of this school. So it's really an honor to be in this house today. And also like to say that being the lead researcher for the Brazilian case is a significant responsibility. We are now in the Brazilian week here in King's, so I can hear many Portuguese voices around. So I hope to make the case for and show how Brazil has a lot to offer to the case of deinstitutionalization. The Brazil has arguably one of the most well-known, internationally recognized experiences of deinstitutionalization in the Global South, a history that everyone that works on mental health and the mental health field has listened about. It's a very remarkable case. And it's a history that has been written and rewritten many times. But this project wants to bring and explore new perspectives on that history. So to start with, I would like just to talk a couple of words about my background and how I come to be here participating in this project. I have some images of previous work that I have done in São Paulo and in Colombia. I am a clinical psychologist. I graduated in Brazil and I did my master's in public health at the University of São Paulo, where I began investigating the process of implementing mental health reforms in the city of São Paulo and how it adhered to principles of equity while shifting its mental health care model. So this was my master's degree where I really became acquainted with the difficulties of implementing a mental health reform and how equity was such an important value, especially in Brazil in the context of SUS and how it struggled to implement this reform. I subsequently moved to Europe, where I conducted extensive research in a similar but distinctly different reform process in Portugal. And this research focused on the creation of psychosocial services, the inequalities and challenges faced by family caregivers in community settings. And it's incredible how when you come from a setting and you have a certain idea of what psychiatric reform is, especially coming from Brazil, and you get acquainted with a new country and a new scenario, you realize how different this can be and how political process is difficult and challenging, and it can be something that is supposedly to be very similar. We're always talking about the institutionalization, but it can be something completely different. And I think it's really amazing. It's how I started to think about this idea of transiting and how Latin America has some particularities that are very different from other contexts. I have then, since my PhD thesis, I have been conducting research in the outskirts of São Paulo with a team at the Department of Psychiatric Epidemiology at the Medical School of the University of São Paulo. And I have completed a 2-year postdoctoral research at the Center of Culture and the Mind in Copenhagen, where I started to investigate a different context in Latin America, which is the case of Colombia, investigating the role of mental health policies in the context of peace building. So this is also something very interesting, how in Brazil it's also often framed psychiatric reform in the context of democratization, but how in Colombia, very often mental health policies are related to the context of building peace. And it was really interesting experience. So throughout my career, I have worked in a variety of institutions across global North and South, drawing on diverse experiences, disciplinary traditions, and working to build bridges between different reform experiences across Latin America and Europe. I have dedicated considerable time examining key issues that unfolds from the deinstitutionalization process, especially the encounter between psychiatry and the community, especially poor and peripheral communities in São Paulo, but also in other countries in Latin America and Europe. And as I see it, this project will allow me to consolidate all these different lines of research that I have been pursuing so far, that has remained parallel, following parallel routes, but to integrate them theoretically, thematically, and methodologically, looking at psychiatric reforms in from the social science perspective, focusing on Latin America, and integrating ethnographic, historical, and public health research methods. We have spoken how psychiatric deinstitutionalization is often portrayed in black and white images, right? But I think in Brazil, this is a very vivid and alive movement. So I have some images here. I was discussing with a colleague here in the audience about the presence of psychiatric debates in Carnival, for example, in Brazil. So this is a samba school, how people come out, and you can see it's called Liberdade ainda que tantan. So liberty is, even though tantan, tantan is how people often refer to madness in Brazil. This person is tantan, but it's also the sound of the drums, and people come to the street, and it's a joke about how to occupy and to build this idea of citizenship, but also a very politicized movement. As we can see here, people every year on the 18th of May come to the streets, and they still fight and struggle for a society without asylums. And I would like to discuss a little bit what it means, psychiatric deinstitutionalization in Brazil, because it's much more than just overcoming the institution of psychiatric hospitalizations, of psychiatric hospitals, and its replacement with alternative services. But in Brazil, this process gave rise to a very particular way of thought about what is mental health care, how do we care, how we think about integrating people within the society, what is citizenship for everyone. And I think it's a very particular case regarding to that. The struggles for the anti-asylum movement, or how it's called in Brazil, it's not anti-asylum movement, but the movement of fight against asylums, as it is locally called, later joined forces with a broader movement for psychiatric reform, which can be seen as a much broader process of social mobilization. And in Brazil, psychiatric reform is not seen as a political, just a political act, but as a movement. It's always the movement for psychiatric reform, the movement against asylums. So it's a very interesting way to frame the institutionalization as a social movement, acknowledging its strength and legitimacy from its political power of social mobilization. I think this is a great feature of the Brazilian context. So just to talk about some milestones of what is the Brazilian case, we have been discussing about these linear discussions about what is psychiatric deinstitutionalization. And here I have some images. I think I chose same images as Devora did, the same image of Basaglia and the same image of the hospital. And I think this is a hospital that Basaglia actually visited in Minas Gerais in Brazil. And here's an image of Foucault when he came to Brazil. And where's my paper here? So in this period, which I call the early mobilization period from 78 to 86, Cristian also pointed that this refers to a period of time while we were still under dictatorship in the country. There was the formation of mental health workers movement, MTSM, following a strike in Rio de Janeiro. It was a moment where workers from a psychiatric hospital just declined and said that it was no longer possible to work in such institutions in this degrading kind of situation. So they came out to the streets and started this movement, and this is the beginning of the movement for the reform in Brazil. It's also at this time that there is the first symposium for psychoanalysis groups and institutions that took place in Rio de Janeiro in 78, which featured leading international figures such as Guattari, Basaglia, but also Goffman, Kestel, among others, discussing the role of institutions in mental health. And Foucault was also in Brazil several times during dictatorship, 5 times, I guess. And this helped to create the intellectual foundations for the Brazilian mental health reform. It's interesting that this is a moment of openness to innovative models, to discussions, international debates that in Brazil actually follow a very different and close trajectory in the years that follow that I will show. So it's this moment of openness to ideas of democratic democratic psychiatry, for example. In this moment, that is the end of dictatorship, but then it's a much more endogenous project that will follow. The second period is the emergence of the movement in the end of the 1980s and 1990s. There is what we call the conference, is the National Mental Health Conferences, Bauru, that Cristian spoke. There is the Federal Constitution in 1988 and this transition to democracy. And as these debates actually started to gain recognition in the society, there was this proposition of a federal law to implement the reform, which only took place over 10 years period. But this is the moment of consolidation of a formal movement for the reform. And in the 1990s until 2010, more or less, there was this process of institutional consolidation, I would say. It's a moment where Brazil saw really a grown-up movement for the reform, institutionalization of the policies. And in 1992, for example, while the first conference in 87 had 350 workers, in 1992, over 1,500 delegates were actually present in the streets, leading to grow municipal and state level legislation supporting mental health reform. So it's really a process of reform that is based on people coming to the streets, getting space and scaling up to institutional change. Nonetheless, during the past 10 years, more or less, we have seen lots of criticism towards a setback in the politics, in mental health policies. In 2016, there was the impeachment of President of Brazil, Dilma Rousseff at that time, which marks the beginning of significant policy and institutional reversals. Also, we had Brazilian, the Bolsonaro presidency, which also changed the leadership of mental health secretariat. There's the slowing down of CAPS and alternative services expansion, but also the strengthening of therapeutic communities, which is a much contested kind of services that don't follow the same principles of the reform. So it's an important setback that started to took place. And I have highlighted some features of the Brazilian case to this project, which I think makes the case really important for us to look and try to challenge this kind of linear debates, linear presentations about what mental health reform is about. And there are important features here in the case of Brazil. We have here this idea of the scale and scope of the reform. You saw the images and the size of Brazil. So you have the challenges of seeing a country that is so vast, but also with a reform that it's a really complex reform. It closed many big hospitals, but also created services in places such as the Amazon region, all the Northeast from the South. So it's also a very complex context, Brazilian case. It's a country that there's limited resources, makes the case really interesting, and a lot of cultural complexity too. It's a bottom-up trajectory. It's much more than a reform and a new health culture. This is a saying of Capistrano, which is an important sanitarista, as we call it in Brazil. The idea of fighting inequalities and pursuing universal care. So it's not just about changing the institutions or looking inside mental health domain, but also integrating this debate within a broader health system reform. I think the alignment of ethical, clinical, and political dimensions is really important in the Brazilian case. And also this idea of territorial engagement, this idea that psychiatry and mental health should actually come to the streets to intervene in the territory. And also we should learn from the recent setbacks. What do I want to do with this project? And I think this is a really important and my final slide. So in Brazil, there is a well-established body of literature on the process of psychiatric reform and deinstitutionalization. In general, it presents a fairly linear account of the historical process, describing the national situation and the influence of international models and ideas related to the institutionalization. So in this first beginning phase, there is this broad debate and presentation about what the mental health reform is about. But also there is an important body of work that looks at the reform process from within. So when we look at the Brazilian literature that has been produced over the past years, there's not in international journals or written in English. There's a lot of innovations, there's lots of production. And I really want to connect these two debates to really understand how there were actually mingled together and knitted together to form and give substance to the reform in Brazil. So this is the first thing that I want to look, is to really to connect these two strands of the literature. But also I want to compare and contrast the cases of Brazil and Chile, looking at the Brazilian case in the context of global circulation of knowledge and including Europe and USA. So the idea really to bring the debate towards the global agenda. And this is all. Thank you. In the zero.
Perfect. Yes. Saw me circling the zero. Thank you so much, Felipe. And now it's my great pleasure to invite the second case study to the stage, presented by Sofia Bowen. Sofia Bowen is a medical anthropologist who has a PhD from King's College London, and she has conducted field work on mental and occupational health in Chile, focusing on the lived experience of distress, medical bureaucratic power, and institutional responses to harm. She has taught anthropology in Chile and worked in interdisciplinary teams on public health. Her work examines how suffering is recognized and contested within psychiatric and bureaucratic systems. It's a great pleasure, Sofia, to hear your talk, which is entitled Researching Psychiatric Deinstitutionalization in Chile, History, Politics, and Ethics. Thank you.
Okay, thank you. It's a great pleasure to be here. Thank you, Cristian, for this invitation, and to the whole team of the Transition Project. I was a student here at King's, so as I did my PhD in the Global Health and Social Medicine Department, so it's a great pleasure to be back here with a new project. Yes, perfect. Thank you. And I also want to thank, obviously, King's College London, Wellcome Trust, and the School of Public Health in the University of Chile, who is hosting this research. I am the second postdoc of this project, so I will show a little bit of the case of Chile. Yeah, I will go through some of the history of the institutionalization in Chile, and show some of the political and ethical dimensions that could be relevated in this project. Just to say, this is a very early approach to the project, because I still have to do the whole research, right? But my background is in medical anthropology. So during my PhD, I carry out an ethnography to explore the intersection of mental health and occupational health in Chile. So I did a ethnography about the experiences of psychic suffering and of psychiatric practice within occupational institutions. So now, as part of the Transition Project, I am asked to do something a little bit different, to approach more to the history of mental health reforms in Chile. And this will allow me to continue exploring some key questions that emerged during my PhD, which are particularly around how people experience of mental suffering become institutionally, politically, and ethically recognized as somebody who is worth taking care of. But also the project will allow me to expand the research, the reach of my research, actually, towards a more historical approach, and situate the Chilean experience in a global context. So yeah, what do we know about the Chilean deinstitutionalization process? We know that over the decades, the process has been shaped by intense ideological and epidemiological debates, and it was mostly driven by a productive alliance between the Chilean government and the academic sector, very different from what happened in Brazil, right? And the process began in the 60s, about 3 decades before the Caracas Declaration, and emerged during a period of widespread revolutionary thinking at the time. The early debates were highly creative. They created new solutions, and they have a strong political vision of social transformation. However, the process was interrupted during the dictatorship, and then it returned with the return of democracy, but in a different way. Yeah, and this is the process after the democratic return. We were able to create, develop a more operational approach that is based on community-based services. I will show a little bit more in more specificity these three. I divided it in three stages. So the early stage is happened during the 60s and early 70s. Okay, and this was a process that we were in a context where institutions were prominent, right? And mental health care was not part of the primary health care at all, or any healthcare really. So what happened here was that some academics from the University of Chile and other institutions and who were psychiatrists started to propose different deinstitutionalization projects, and in Santiago and other cities. One of them is very known in Chile. His name was Juan Marconi, who is in this picture over here, and he thought about a way of imagining psychiatry and deinstitutionalization, not just to oppose the asylum, which was part of a critical part of it, you know, but also as a political proposal. Psychiatry was a way to liberate people as well, to make a revolution. So that is why he called it the cultural revolution in mental health. So this is a time of profound political change in Chile when the country was moving towards socialism. And the political leaders like Salvador Allende, who's known in social medicine, right, in Latin America, was a political figure at that time, and he was promoting health as well as a space for political participation and social justice. So, for example, just to give you more details about what was this project, he called it community psychiatry, and it was a way in which psychiatrists have to work closely with the community, understood more like a mobilized popular sector, a working class. And the community and the experts, they would delegate their knowledge to local actors. And the responsibilities of care will be delegated in a system that was hierarchical, like in a way that everyone will be part of the caring of other people in a community, or key actors, at least leaders inside of the community. So this was a little bit, he was inspired by Maoist ideologies, and as well also behavioral psychology as well. So he also addresses specifically alcoholism, which was something that at this time the psychiatrists were very worried about, and they saw alcoholism as a problem of social injustice, as a reflection of social injustice. So this project was deemed very successful. They managed to measure it epidemiologically with pioneering tools to know that alcoholism levels were going down after the interventions. But this happened to be stopped during the dictatorship, because it was a right-wing dictatorship, and this was viewed as something that needed to be stopped. And they, all of the leaders of these projects were persecuted, and mental health care was re-centralized into psychiatric hospitals, right? But during this time, there were NGOs as well that created a very innovative way to understand mental health as not just as something that we need to address individually, but also something that, because they were trying to attend people's need after being victims of state violence, right? So they thought of this also as a political statement, to think about mental health as a way of rebuild the social fabric of the society, to mend all of the damages. And from the 90s onwards, with the return of democracy, Chile started to carry out a steady process of mental health reforms, with moving such a little bit of setback here. So thank you, Cristian. What happened here was a process of mental health reform. So the first one is in 93, then the second is in 2000, and the next one in 2017, which all emphasize the community mental health care model, the importance of mental health care in primary care, following very closely the Caracas Declaration. So these reforms allow the implementation of protected homes, day centers, community mental health centers, etc. And they also recently, just recently in 2021, in Chile's first mental health law, one of the articles prohibits the creation of new psychiatric hospitals. So this whole process have reduced long-term psychiatric hospitalization, and even some infrastructure was closed or repurposed, like in the hospital El Peral in Santiago. But also there are still a lot of challenges, mostly derived from the fact that all of these reforms were enacted during a time of neoliberal healthcare reforms at the same time. So it's kind of like a very contradictory as well. But there is a lot of like issues of budget, obviously, but more of that, there are issues of how do you implement community level solutions when community is so fragmented, right? So right now, new mental health law is under debate, where are new actors starting to have more importance, like maybe users that they weren't as much before in Chile, and also caregivers, right? So some features, to just summarize what I just said, I think we can look at Chile's case as a case that shows us an ongoing non-linear process of deinstitutionalization, shaped also by setbacks and then comebacks after time. Also how it has a very strong political history, especially in the early stages, which still resonate, but they're not as explicit as it was before. And also more currently with a more operational technical approach in close relationship with the WHO or the Caracas international ideas of mental health reforms. Then we have also a widespread, we don't have that. It's very different from Brazil. We don't have a widespread social movement, although they have lobbied for better services. They are some groups, they have organized important things. It's not like a widespread movement. And then obviously there are internally contested processes. It is a very contested process inside, both from different actors, ones that are against the deinstitutionalization because they still believe in some ways of the importance of these institutions in different forms, and others that are critical of this model, the operational technical model, because they feel that it is lacking all of the political history and all of the actual capacity of transformation that it should have been having for them. You're right? Yes, so what are my research aims and methods? First of all, different also as Brazil, we in Chile don't have an extensive literature and an analysis of the process, of the historical process. So the first thing is to examine Chile's psychiatric deinstitutionalization historical trajectory and how it relates with the broader social, political, and economic processes of the country. I will try to focus in understanding in detail all of the process that I just told you, right? But more in details, what are the specific cultural and ideological configurations, the epistemologies, the solutions, and the challenges that all of throughout the history, right? And for that, I will do interviews with key actors who took part in the process, and also archival research and analysis of gray literature, and go back to every hidden paper that I can find that can tell me more about this story, like more about this history. And the second goal would be to examine the current ethical and political tensions that are shaping the psychiatric deinstitutionalization in Chile and how it's experienced from the ground. Yeah, because in a similar way that I did already in my previous research, in my PhD, I will do an ethnographic case. I will try to understand how the psychiatric deinstitutionalization is actually experienced, not only by the people that are trying to implement this change, but also by users or caregivers, and how they move around different layers of the process, in different layers of the institutions and services that they have to go through, no? And to understand the actual experience and the challenges that come from the ground. Yeah. So the transversal research questions that work to the historical and also the present are, first, how the socio-political context shapes psychiatric reforms. What are the different voices? What are the different actors? How they experience and negotiate the institutionalization in their spaces, right? And what are the context-specific ideologies, epistemic views, challenges, and how they contribute to the understanding of a Latin American or a Global South vision of mental health and rehabilitation. That's would be it. Thank you.
Thank you so much, Sofia. And now it's my great pleasure to introduce our last talk for today, which is called a host intervention. And I welcome Hanna Kienzler to the stage. Professor Hanna Kienzler is the co-director of the Center for Society and Mental Health here at King's College London. She is a medical anthropologist who focuses on mental health in context of systemic violence, ethnic conflict, and humanitarian crises. She has conducted extensive field work in Kosovo, Palestine, and the MENA region, and led major international projects on mental health and justice and on mental health in conflict. Her work combines ethnography with global health policy analysis, with a particular focus on lived experience, trauma, and social suffering. Welcome, Hanna.
Yeah, thank you very much. And I follow Felipe. So you're not alone sitting because I did prepare a bit of a paper, and I hope that is okay. So thank you, first of all, for inviting me to offer reflections on your really wonderful project. And in my talk, which I'm calling Between Rights and Realities, Rethinking Deinstitutionalization and Community Inclusion from the Ground Up, I want to explore some of the promises, assumptions, but also challenges related to deinstitutionalization and community inclusion for persons with severe mental illness, and focusing on how these ideas play out in complex and often under-resourced settings. I will be drawing on ethnographic research from Palestine, where I examined the assumptions embedded in global calls for deinstitutionalization and highlight the disconnect between legal frameworks, lived experience, and available support, as well as the opportunities of how these sort of disconnects can be bridged. So there will be a constructive also ending to this talk. The talk I divided into 3 parts. The first one I have titled The Dominant View, Institutionalization, Deinstitutionalization, and the Right to Live in the Community. So the UN Convention on the Rights of Persons with Disabilities was adopted by the United Nations Nations headquarters in New York in December 2006. It was open for signatures on the 30th of March, 2007, with 82 signatories to the convention, 44 signatories to the optional protocol, and 1 ratification. This is the highest number of signatories in history to a UN convention on its opening day. The convention entered into force in May 2008 and has now 192 ratifications and 164 signatories. It is intended as a human rights instrument, has an explicit social development dimension, and includes people with mental illness in its definition of disability. A key cornerstone of the convention is its advocacy for deinstitutionalization, that is moving away from placing persons with disabilities in institutions and instead supporting them in the community to be included and to live independently on an equal basis with others. Despite immense effort, the CRPD guidelines on deinstitutionalization, including in emergency, highlights that institutionalization is still widespread and is linked to violence, neglect, abuse, ill treatment, and torture. It states that people are placed in institutions under life-threatening conditions as they are deprived of their liberty. As such, institutionalization is in direct contradiction, or is perceived to be in direct contradiction of the right to persons with disabilities to live independently and be included in the community. This thing doesn't quite work. No, but I'll be moving. That's fine. I can talk from here. So, and this right is enshrined in the Convention's Article 19, which states, and I quote, "States parties to the present convention recognize the equal right of all persons with disabilities to live in the community with choices equal to others, and shall take direct effect and appropriate measures to facilitate full enjoyment by persons with disabilities of this right, and their full inclusion and participation in the community. This includes opportunities to choose one's place of residence, access to community support services and personal assistance, and the accessibility to mainstream services that are available to everyone. Importantly, the CRPD guidelines argue that there's no justification to perpetuate institutionalization, no matter the lack of support and services in the community, poverty, or stigmas. Instead, states must reform systems to provide individualized, personalized support through diverse options. This also applies in emergencies such as wars and natural disasters, where persons with disabilities are often most at risk. So this brings me now to the second part of my talk. What is so important about community living? So what is the moral foundation for the legal human right to live independently and be included in the community? What is so important that community living is enshrined in international law? My former PhD student, Dr. Emma Wynne Bannister, and her primary supervisor, Dr. Sridhar Venkatapuram, have explored these questions through the lens of the capabilities approach. They state that the capability to live in the community is morally valuable as a core aspect of well-being because of humans' innate inherent sociability. And they also argue that it is instrumentally valuable as it helps pursue other capabilities that make up decent, flourishing life. The capability approach considers human capabilities to be what people are actually able to do and be in their daily lives. It is about having real opportunities, which are called functionings, like being able to work, learn, make choices, and take part in community life. And that allows individuals to live, it is argued, to live in dignity, a life they value. Similarly, Martha Nussbaum has argued much earlier that by being included in the community, and I quote her, "Human beings enjoy status, dignity by virtue of their humanity, that is, by virtue of their membership of first, the human species, and second, the human community." According to Wynne Bannister and Venkatapuram, this means that we cannot advocate for deinstitutionalization without ensuring the necessary support in the community to carry out everyday activities while living independently. Deinstitutionalization should therefore never mean, as I have heard from some CRPD proponents, that anything is better than institutionalization. It should not be about leaving people to fend for themselves, also something that I've heard, an erroneous notion that views community living as a matter of physical placement. But this is not what the CRPD argues. It lacks conceptual clarity about what community means, how support is best provided in a meaningful way, and how we should relate to one another to uphold human rights, freedom, and dignity. So this now brings me to the third part, where I want to explore underlying assumptions about community living versus lived experience. So what I want to argue is that both the CRPD and the philosophical argument for the capability to live in the community as an equal member make key assumptions that warrant a closer look. We have partly done so in a recent paper that you can see here on the ambiguities of social inclusion in mental health, where we compare experiences with community living among people with severe mental illness in Ghana and the occupied Palestinian territory. And I will report on our case in Palestine here. So let me start with the first assumption. The first assumption is, and we have heard it today, institutionalization continues to be widespread in treatment of people with severe mental illness. While this holds true in many countries, access to professional mental health support, especially for severe mental illness, remains very limited in low-income countries and many middle-income countries. In Palestine, for example, there is only one 280-bed psychiatric hospital serving the entire West Bank. Meanwhile, the 38-bed hospital in Gaza, like all other mental health facilities, are no longer functioning because they have been severely damaged and rendered inoperable by Israeli airstrikes during the genocide. Mental health support is by necessity provided in the community, mainly by family members with absolute no professional support. However, this does not necessarily translate into the aspirations outlined by the CRPD. Accordingly, having fewer institutions does not automatically translate into improved human rights for persons with disabilities, especially for those with mental illness. Assumption 2, community is good for you. Community is often perceived as a desirable and recognizable social space characterized by belonging, connection, support, care, social cohesion, solidarity, collective action, knowledge sharing, trust, and respect. Research shows that people living with mental illness, especially severe mental illness, value meaningful engagement in such spaces, which can have positive impacts on their mental health. However, for people who experience severe mental illness, inclusion in the community also means increased exposure to ridicule, abuse, and discrimination, which has been shown to be detrimental to people's mental health. Our research in Palestine with people with severe mental illness and their carers revealed that they had a rather ambiguous relationship with community. Many experienced community as unjust, controlling, oppressive, and intolerant. Most participants described having been mocked, ridiculed, and having been called majnoon, crazy. One person said, "We are not well integrated in the community. This makes us feel uncomfortable, and we keep thinking, why are we not like them? We can be like other people, but they don't allow us." Nevertheless, communities also offered communal spaces that those with mental illness felt that they could frequent, albeit not without a struggle. These included neighborhood cafes, shops, markets, pharmacies, and the local mosque, quite a limited sort of array of sort of community institutions. Our research highlights in this the importance of establishing a nuanced understanding of community when developing support mechanisms, given that community as such is not good for people or their mental health. Good community is good for your mental health. The third assumption is for social inclusion to work, the person must be able to behave according to norms and values of the wider community. Not participating appropriately may be judged as a moral or social failure. Our research in Palestine showed that sort of fitting into community depended on factors including the perceived severity of symptoms, family attitudes, and normative expectations of participation. The wife of someone with mental illness told us, "The family understands the situation of my husband, yet other people don't know. I'm afraid something will happen, putting him and us in an embarrassing situation." Similarly, a mother told us about the embarrassment she feels when her daughter behaves in ways that do not constitute proper behavior and ground for participation. She said, "I do not tell anyone about her mental illness, yet all people know. I also take her to the sheikhs. In the afternoon, after 3 until midnight, she starts wanting to go out of the house. She starts hitting us and goes out into the street without having any clothes on. So I always hide the key. I feel she has a mental illness. She's bewitched from within." That said, we also heard that family members stand up for people with severe mental health issues, especially when they learn about violence that is committed against them, whether in the community or within the family. And they also provide carers with support and some respite, given that there is so limited professional support. So what these examples reveal is that participation in community assumes particular ways of participating that leave little space for behaviors that don't fit the norm. Assumption 4, community inclusion operates in similar ways everywhere. However, meanings and values associated with inclusion and the practices through which it is realized vary between contexts, individuals, and are shaped by embedded hierarchies along intersecting lines of gender, race, ethnicity, age, etc. And this can make community inclusion more achievable for some than for others. In Palestine, community inclusion had, for example, a particular gender dimension in that it was much easier for men than for women. However, community inclusion and participation were also shaped by political factors and not just social and cultural ones. The Israeli military occupation and related violence further exacerbated exclusion and isolation. Accounts of soldiers entering homes, arrests, shootings, and public humiliation were recurring themes in our research. A woman, for example, reflected on her brother's increasing isolation, saying, "When there are clashes, he won't leave the house. If the world would burn outside, he would not go out. He even doesn't go to buy cigarettes." Israeli violence not only isolates those with mental illness, but also often tainted caregivers' engagement with the neighborhoods and communities they lived in, infusing it with fear and trauma as they recalled the mistreatment of their family members at the hands of the soldiers. For example, a mother of a female former political prisoner with severe mental illness shared that whenever she steps out of the house, she remembers how her daughter was captured by the soldiers. Crying, she recounted, "I always remember how the soldiers came and took her from the house. They took her out without shoes. It was very cold and they made her sit outside on the ground." So although the CRP addresses war and conflict explicitly, has its own article, it offers little guidance on how to adapt rights-based approaches to volatile contexts in socially and culturally appropriate ways. And this brings me to my concluding statements where I want to have a way out of this, or I thought it would be important to think productively. So I want to make a proposal for pragmatic complexity for community inclusion and participation. Community inclusion should not be seen as a static endpoint. Instead, my colleagues Suzanne Mitwalli, Miriam Zizek, and I argue for a model of pragmatic complexity. Complexity, we argue, must be acknowledged by considering different histories, political structures, and sociocultural contexts. This must be balanced with what is actually possible in settings with limited resources or where much of the population struggles with independent living, such as in Palestine under Israeli occupation. Adopting the concept of pragmatic complexity by Ansel and Geyer, we highlight the complex and changing nature of community inclusion for persons with severe mental illness. So community inclusion must be seen as emergent with evolving strategies shaped by shifting contexts, new insights, and diverse knowledges. Ansel and Geyer argue that such fluidity challenges policymaking and advocate for combining complexity with pragmatism grounded in democratic learning and dialogue. To achieve community integration in war-affected settings, we propose a dialogic approach based on 3 premises. The first one is community must be built through participatory approaches. So needs assessments, support, development, and evaluation must include persons with mental illness, families, employers, service providers, policymakers, and the general public, importantly. Second, such participatory approaches should be designed with a human rights perspective in mind, to give attention to survivors of violence, people displaced by violence, loss of loved ones, and family and community disintegration. Community disintegrates in times of war. It is not whole or wholesome. Third, the development and provision of support for community living is an intersectoral endeavor. So we propose that community integration must be developed, supported, and evaluated at the intersection between households, communities, services, and national policymaking. Among households, it will be crucial to provide resources and social support across extended families, with a particular focus on women who are often the main caregivers in such contexts. In the context of the community, it is important to create information systems and raise awareness about mental illness, carry out community needs assessments, and enable community involvement in creating environments that welcome and integrate persons with severe mental illness, and this is not easy. With regards to services, it is crucial that mental health and psychosocial services are made broadly available in both urban and rural areas, that attention is paid to pluralistic medical traditions, and that effective referral systems are created. Finally, national policies must be geared towards protecting the human rights of persons with severe mental illness, poverty reduction, and implementation of national policies, ensuring access to education, employment, decent wages, healthcare, and housing for those with severe mental illness, while also providing support mechanisms that allow equitable access to opportunities and services. However, laws are insufficient. Community buy-in from the outset is essential, and this work must be rooted in solidarity, relational practices where individuals and institutions accept costs to support others with whom they recognize a shared condition, possibly a shared humanity. That would be nice. Evaluating solidarity-based approaches is vital to sustaining commitment and understanding broader impacts, especially in unstable contexts. It is only then that deinstitutionalization can truly lead to dignity, autonomy, and belonging. Thank you.
Thank you so much to all of our fantastic speakers. And we have now about 20 minutes time for an open conversation, Q&A of the speakers, but also really to engage in a lively conversation. And maybe I ask all of our speakers to come to the front so that the audience can address the panel. And we also have people online who will be able to either post their questions by unmuting themselves when we turn to them, or Maddie will also monitor the chat and feed questions in. So the floor is now open to all of you for your questions, comments, interventions. Maybe introduce yourself quickly so we all know.
Hi, I'm Valentina Yemi, University of Essex. Thank you for the amazing presentation. This is definitely an incredible project. I have a question that cut across all your presentations. You're definitely interrogating the concept of mental health as a political concept and the role of mental health as defined by the political context in history and at this time. I wonder whether you can tell me more. How do you want to redefine mental health in such term or play with this politicization of the concept? Thank you.
I will say something briefly, and I would like to maybe respond through an example, because we do talk a lot about politics and mental health, and sometimes the discussion is very abstract. But one example in South America was the struggle for human rights in context of dictatorship, and how using mental health as a platform for advancing values that were actually outside of mental health as a specific kind of a medical field. Using mental health to talk about violence, to talk about democracy, to talk about the need for freedom. This is something that was in common with different scales, but in common between Chile and Brazil. And I know that it was the case for many countries that experienced dictatorship, which is very different in the way in which psychiatry was used in context of authoritarianism to, for example, what happened in Eastern Europe. It's very specific. But that's an example of what could politicization mean in context of authoritarianism, in context of populism, in the context that we are kind of seeing multiplying in many parts of the world. That would be my answer.
It's working, yeah? Yes. I was thinking, I wish it's not so politicized. Because as a consequence, okay, there have been opportunities that thanks to being connected to the human rights and so on, then people could have could change the situation, could generate reforms. But I think, at least for me, it's way more than ideological issues. So it should be less politicized, and there are some technical key issues that are systematically ignored that I think should be taken into consideration. By being so linked to political issues, then it is manipulated as well. And then there are, according with some of the colleagues showing the trends, and I know a bit also more details about these two cases, it is completely slapped back and forth according to who is in the political government, and that is not good. I was thinking also, listening here, the situation of the 30,000 people living in institutions in Ukraine when the war started, when the invasion started, and people there abandoned to themselves, as it was mentioned at some point. And okay, but we could maybe at some point use that and insisted. Now, deinstitutionalization is a priority for the government as well. So, sometimes it's convenient, but I wish it was more something to do no matter what.
Yeah, maybe to add, I just do think it is political, and our funding is political, our demands are political. There's just no way out. And just again, very brief example from Palestine, where after the Second Intifada, needs assessments were created to reform the mental health system, to make it more sort of public health, like more community-based. Funding was sort of pumped in through international donors. Then in the West Bank, Hamas was democratically elected in 2006, and the international funders cut all their funding, destroyed everything that was going on, all the developments, everything was put on hold. No salaries, no programs, no training, no proper support in the community, etc. Then the West Bank besought itself. A bus was put in place again. The funding restarted. We had another needs assessment, then another needs assessment, had to then focus on resilience, because now one has to be resilient in the face of extreme violence. That's what the international community wants. So, and I'm stopping here, but just to say, the reform process itself, as they are dictated also from above, while also emerging from the ground up, cannot be sort of divorced from politics, whether we want it or not. That's just how the world turns.
Maybe we could take a few questions.
Maybe we will collect a few questions and you take notes on which ones you want to address.
Thanks so much. I'm Antonis Kosoulis. I'm with United for Global Mental Health. We work very closely with Devora's team. So I lead the Global Mental Health Action Network, which is a community of 7,000 advocates from 170 countries. We're soon going to start a dedicated advocacy work on deinstitutionalization around the world, led by people with lived experience of institutionalization. We know how you can help us, because we need evidence, we need good evidence, stories, understanding the nuances that comes from your important work. My question is an offer of help, and how can we help you in your work as advocates and policy influencers? How can we help your work and work more closely together? Because sometimes, we work in silos, and that's not great. Thank you.
Hi, I'm Agostino Carbone from University of Rome, Italy. My question is about the involuntary psychiatric treatment. In Italy, after the Basaglia law, we had a reducement of a psychiatric involuntary experience to be treated in psychiatric hospital. My question is that if in Chile and in Brazil is also still used to do an involuntary psychiatric treatment, and which rate it will use in your country. Thanks.
One more, and then I'll hand it back to the panel. And there's someone around.
Yeah, thank you for a really fantastic presentation. Really lovely to hear about this project. So my name's Jason. I'm a PhD student at King's. My question was really building on the colleague, the global advocacy, and it's great to see. I've never met you in person, but I follow your work as well, and Devora as well. I follow your work as well. But yeah, just how are you really meaningfully going to include people with lived experience across Brazil and Chile, and how is that knowledge going to translate back into the UK?
Again, I will start. Okay, so I will address the first and the third question, and your question I will leave my colleagues to talk a little bit about. In terms of advocacy, I think this brings us back to politics, because in the advocacy processes in the 70s and 60s, they were very kind of a cross-disciplinary, involving activists, involving advocacy, involving intellectual and scientific work at the same time. And I think we need to kind of learn how to do that again in a fluid way. We are completely open, and this work is based on participating in advocacy spaces. I think to a certain extent, for deinstitutionalization to be perceived as an issue, it requires kind of a prior disposition that I would say it is an advocacy disposition. It's not something that you see as a problem right away, which is a problem actually. You don't see it as a problem right there. You think, okay, there is an institution, there is treatment, there are professionals, they know what to do. We can move on. To see it as a problem, it is kind of a disposition to change things. So yeah, that kind of is our approach, and open to absolutely work. And we've been in touch with Ali about this already. So it's great work that you're preparing. And then moving to the third question, which for me is a very important one about lived experience. So the project itself, it's based on an ongoing conversation with activist spaces in Chile and Brazil, particularly autonomous service user groups that I've been working with since my PhD and then in the context of this project as well. And we know that not all service user groups work around the institutionalization directly. Some of them have other priorities in terms of the advocacy that they do, but some do. And so we are working with the groups that are part of the discussions and the vision and the vision of transformation. Particularly in Brazil, that is more common, that service user groups are engaged in this kind of popular anti-psychiatric asylum movement. In Chile, groups are more fragmented and they have more specific concerns. And we are working with the ones that are involved in this particular area of work. So that would be the response.
Yeah, maybe before going into the specifics, the issue of involving people with lived experience, depending on where the process is. Because if reforms have been taking place, led by another generation, the people with lived experience that are now more vocal, more active, are younger, and they don't know what is that they escaped from. They were never confronted with that. And that's then also some difference, that you talk to people that are not interested in something that has not been their life, their reality, right? They're interested on other issues. And this you can see also in the case of Brazil, sorry to enter there, where the power of those pictures that we have seen are harder to find today aligned into a reform, because most of that took place already. So the challenges today are different. I happen to be in the latest of these conferences that are 2,000 people in the room. It's amazing. And the arguments and the fights are different. So, it depends on the timing and the processes where they are.
Can I add something? I just wanted to add that I think as an anthropologist, I feel like it's very important to, if you want to understand lived experiences, you have to understand the nuances and the complexities, right? So that's why I think it could inform much better the different experiences that happened in different types of institutions. For example, it could be very different to have an experience of someone that is experiencing daycare or a protected home, and then it moves to an institutional, to the hospital for some days, and then moves out. And then I am interested in to see that transition, that movement, without just looking at a very a static understanding of the experience. Yeah.
So just to say a couple of words, I think regarding the case of Italy of involuntary hospitalizations, this is an issue that is coming and going in Brazil. It depends on different policies. So sometimes it has become more consensual that it can happen, involuntary hospitalizations, but we also have setbacks, and involuntary hospitalizations in certain cases are still frequent, especially in deprived communities and some parts of the city, depending on the government and local government specifically. So it's not a consensual policy in the country still, even though it's the general policy really avoids or stands against involuntary hospitalizations. Regarding participation, I think, yeah, for me, it's also a very important topic. I have been working with this with Cristian and with other colleagues. And I think the key idea is to think on improving the repertoire on how participation happens, and thinking about an agenda for participation that is not set by just large frameworks such as deinstitutionalization, but also working with people to know what is important for them. And I think there are different stakeholders that have very different and important positions towards this. And I think what we ambition to bring is to enlarge this repertoire of participation and what have been learned in different contexts. And we hope having a larger repertoire, it can help UK, but also we should learn from UK and from elsewhere. But the idea is really to open our minds to different ways of thinking about what is participation, how, which kind of challenges do people face in the community. I think Hanna also speak beautifully about places in war zones or conflict zones, very different than spaces in poverty or racial inequalities, which we see places have different kind of challenges. And I think we really have to learn from the variety of experiences.
Can I just sort of quickly add, or maybe even challenge you a little bit with the projects, because you're talking about service user groups. It relates to the point that I was making about what is acceptable behavior, what is acceptable participation. But I feel in certain service user groups, there's a certain type of person who participates, it's certain communities who participate. There's a particularly scripted way of participating, and who we often don't hear is those people who are not connected, the voices that people who are marginalized, and the marginalization is intersectoral, right? It's intersectional. It's along race, it's along gender, it's along religious affiliation, etc., etc. So to make sure that not only the dominant voices get heard, but also those who are excluded, who are much harder often to work with, because they are excluded. So just sort of an invitation to really be inclusive and do the hard work. And I have mainly worked in places where there are no user groups. It is hard work. It takes time. It takes 5 years to produce something meaningful, but it's worth it. So just an invitation to really make sure to be alive to the marginal within the marginal.
Should we check in with the online chat for a second, where we also have a few questions, and then we return to the floor?
Yep, so we've got a few questions from Zoom. One says, thank you for the wonderful presentations and for introducing this fascinating project. Can you please comment on the role of the prison system as a new form of institutionalization? And is this relevant in present day Brazil and Chile?
Shall we collect a few more?
Yeah. So that's question one. And then question two. Thank you for the presentations. In your view, does deinstitutionalization as a concept and paradigm relate to others, such as decolonization, abolition, and perhaps more broadly, emancipation, and how? And then the last question is, do you have any thoughts about how meaningful and lasting reform might happen in the UK?
That's a good one.
Over to you.
Okay. Again, I will try to
Cristian
give.
starts.
I will. So, two main things. So, part of the complexity of the institutionalization it's that it is connected with a lot of things. It touches upon service provision, funding, regulation, geography, inequality of all kinds, professional identity, professional trajectories, the differentiation between psychiatry, social work, occupational therapy. There are so many lines in which you could trace this process and which you could look at this process. And this is a challenge. It's something that we are kind of co-constructing as a team and with our partners, how to address this. And also considering the differences between Chile and Brazil that we had a view of. I think that listening to that question, I think the question itself is symptomatic in a way of what we're trying to understand, because in the early discussions around deinstitutionalization, the main thing was kind of the epidemiological reality. Like psychiatric institutions cannot deal with the epidemiological reality of mental illness. They're just unable because of the scale of the problem. It was a vision of extending services, strengthening a platform of support, creating institutional spaces that could make people closer to the community through primary healthcare, et cetera, et cetera. So it was a very, in a way, institutional view of the institutionalization to a certain extent. But now we have issues like emancipation and decarceration and the connection between different carceral spaces where excluded people, in a way, inhabit and circulates. So instead of kind of addressing that as a question, I think that this is exactly the kind of things that we want to think about, like the contrast between the values of the initial stages with what people expect and how people are seeing, how new generations are perceiving the role of psychiatric institutions in the present and the connection that they have with other spaces of punishment and segregation, like jails, etc. I don't want to go into the all discussion of trans-institutionalization and this connection between people moving from hospitals to jail, because that is a very sketchy evidence base, in all honesty. Just kind of measuring up numbers from one to the other, this doesn't really say much about what happened to people that ends up in these places. So yeah, that would be my general answer. Yeah.
Maybe something on the decolonization question and that nexus, because I find that quite interesting and obviously something that I discuss a lot with my colleagues in Palestine around settler colonialism. So when I came and we sort of thought about the CRPD and the assumptions and the right-based approaches, we had to sort of grapple with the fact that there is an assumption that the rest of the community has human rights. This is not the case in Palestine. That other people are perceived to be fully human. And we can see now occupation on steroids. People are not considered fully human. And within such a context, you can't just impose human rights principles without addressing settler colonialism, without addressing military occupation, and without addressing these injustices holistically. And then within this, create systems that really value everybody, no matter how they are positioned in society. So it's a huge piece of work. And I'm sure there are different questions to be asked in Brazil and Chile, but surely also very, very interesting ones as you are exploring processes of how things are changing from the grounds up, these sort of fluid and various trajectories of reforms, and how people are pushing against certain initiatives while embracing others. So I think there are quite interesting sort of angles to explore historically, but also in the current moment.
Mm-hmm. And just to comment on the issue of both colonialization or decolonialization, it reminded me a lot of work done in the Caribbean versus the UK. So there's plenty of literature there, and I don't think much new might be needed to said. We know what it is how to change practices. I was thinking about the issue of prisons that is beyond the numbers, is the whole common situation of inclusion of versus exclusion of some of the criteria of the community that excludes in Palestine are valid here in the corner. And you need to create communities that are inclusive and that don't send away the one that is not fitting perfectly to the norm, whether it is to a prison or to institutions. And yes, the number in some countries are really wow, right? I mean, like you see you try to close institutions and the number of people with mental health conditions in jail increased exponentially, right? But the principles behind, I think what I like from what I understand from this project is precisely to look beyond the specific of the psychiatric world and look at what is around. So it's valid for every other context, right?
Thank you so much. We have one last question in the audience, and we are also at time. So I would say we make that the last question. No pressure at all.
No pressure at all. I'm Nora. I'm a senior research fellow at King's and also the co-founder with some of the speakers of the platform for social research in Latin America. I wanted to follow up on some of the topics that have been raised, particularly with relation to lived experience. If there's specific methods that you've applied, if people with lived experience have informed the methods that you will be using, if there's co-production or any kind of collaborative research. And then just to follow up on decolonization, I know we are all a bit clear on what that means from continent to continent, but within Latin America, Chile and Brazil maybe have had a bit of a problematic or dominant views in the region. I'm just wondering how you're going to address that if it's a South American project. And
yeah. Just very briefly, and I will leave space to deal with the other aspects. Even before I thought about Brazil, because I'm from Chile, so Chile is where I have my networks and the service user groups and the policy groups and the connections. And then the challenge was, okay, like how do I even start with Brazil? Okay, this is massive, it's super rich. It has a strong literature. It has a lot of thinking around it. So my decision was to work with service users to start with, and to try to understand this totality from the view of a group of people that was trying to get their voices heard in the main mental health meetings in Brazil that are super important. Like to be part of those meetings at the government level means that your demands will somehow be channeled through institutional channels. And I joined their process, like rather than asking them, okay, I want to do this as a researcher, please help me. It was like, I am a researcher, I want to help, because that's my way of understanding settings and understanding the politics of settings and understanding the people as well. And this was like 3 years of being on eternal Zoom meetings with large groups of service users to participate in what they are trying to do. And from there to start to get their thinking about what I want to do. And it gives me kind of a better standing that I didn't have in Brazil and that I do have in Chile, fortunately. So that's my answer to that aspect of the question.
Yeah.
No, I think it's still not very clear exactly what are the methods we're going to use. I think the project has 2 ways of addressing this issue, and which are particularly interesting. One is to look at it historically and to a different kind of panorama, which is looking at Latin America and thinking of how does Latin America participate in a broader project somehow, of what other visions of mental health, of what other visions for psychiatry today actually exist. Another word would be possible if we think as people have produced different ways of thinking long ago, and then bringing it to the present and really looking at how different groups and different people actually foreseeing another ways of dealing with what we are calling deinstitutionalization, which is also a very tricky term. So I think really the idea is to have a very exploratory and openness to think about current challenges and what are the debates, or even mapping literature that is being, because participation now in Brazil, it's something that has so much production. It's not just about participating or making a participatory actually space, but actually hearing what people are actually producing. So I think it's a project, at least from what I see, of consolidating and trying to bring a broader view of what this participatory process, which has been the case in Brazil for such a long time, can produce. So I think there's a more thinking on historical, but also a participatory approach at the same time. It's a tentative framework.
Just to add that in the case of Chile, I talked about an ethnographic case, right? And that would imply to engage directly with people that are experiencing institutionalization or moving between institutions, maybe local community ones and hospitals. And in that sense, I think we have to have like a strong conversation about how we are going to deal with that specific experiences and with with user groups and how we can also collaborate together in something that is the second part of the project. So the first one is the history, as Felipe said. So the second part is that has that challenge, like how are we going to embrace these voices, these different voices, and how we are going to, as Hanna said, how are we going to include not just the users that are organized, and have a voice already, even if it's not even that much heard, but also these people that are not organized or that are living under conditions that we don't really know much, right? And that the caregivers are primarily their families, or that they also, for me, caregivers and family members are essential to include. So yeah, that's would be my aporte.
Great, thank you. Thank you so much to the panel. Please join me one last time in thanking this fantastic panel and wish these researchers good luck with the project. We have in the back drinks and snacks and a bit of a reception. And please bring the questions that couldn't be answered in the main forum to the speakers as we mingle. Thank you so much for coming.